Hey everybody! Today we're here with one of my longtime friends from the Chicago Bears internship days, Timmy Turner. Timmy is over at in Kansas, going to PT school as well. So welcome. We love having you here, and we're going to knock on some hamstring strains together. So Timmy, go ahead and tell everybody where you're from, what you're doing, things like that.
Awesome. Well, thanks, Jake. I really appreciate it. Same to you, JJ, for having me on the first time and talking to the athlete engineers. These guys are doing some really cool stuff with just getting information out to people who need it about their bodies and how to perform in an optimal manner. Like Jake said, I'm Tim Turner. I'm a current student physical therapist at the University of Kansas Medical Center, which is in Kansas City, Kansas. My background is in athletic training, which is how I did my undergrad degree at Kansas State University. Kind of made my transition to Kansas City a couple years ago after graduating, and did some work outside in an outpatient pediatric clinic, as well as a couple training camps with the Chicago Bears. So we've got a little bit of everything. I also have a minor in exercise science and which is, it's kind of like a minor, but doesn't have enough credits to be a full major in gerontology. So I like to tell people that when I was in college, I studied older individuals who like to exercise and like to play sport, but also got injured. So it kind of meshes everything together as far as my background goes. So that's where I've been. Where I am now, Kansas City, Kansas. Looking to go into outpatient private practice. KU's actually just started a dual DPT MBA program that they've had for the School of Medicine for 6 or 7 years, I think. And I'll be a part of the first cohort to complete that program. Looking to understand how the financial aspects of healthcare are changing and what we can do to optimize health outcomes for our patients, not only delivering good care and quality care, but doing it at an effective price and an effective payment model for our insurance. Because I think it's pretty well known that the private insurance industry isn't the best, I would say. I don't think some of those companies have the best outcomes for their patients in mind. They're just looking to save in some aspects. So we'll see where the road takes me. I've still got a couple years left of school here, so I'm excited to see what the next step is.
Awesome, and
We're
we're
excited
just
for you, man.
yeah, we're so glad to have other PTs that want to push the profession forward for the patients. That's the key. We're here to help people. It's not about that bottom line or making that extra dollar. So, all right, let's get into it.
Let's do it, man. Yeah. So Tim, this is something that you and I have been very familiar with. Back in 1998 to 2007, there was a 10-year study that went over players in the NFL and the occurrence of hamstring strains, which are our topic of today. And it found that hamstring strains are the most populated injury in the NFL, only secondary to knee injuries. Only 1/3 of hamstring injuries usually recur with the greatest risk during the initial 2 weeks back to return to play protocols. I mean, this is something that we've seen in the professional world with Chicago Bears. Is something that you can see on TV all the time with Chris Paul last year in the NBA series for Houston, dropping the ball there. He's been having some issues ever since then. It's something that's just a chronic issue that a lot of people don't understand the biomechanics after injury. They don't understand when to come back to sport or what the rehab is supposed to look like. And really, it's just a prevalent injury that is probably one of the most preventable injuries in all of sports. Is there a hamstring strain that you've dealt with recently, something that you've seen in the training room that's been interesting to you? Any rehabs you've done in the last few months that have been kind of piqued your interest?
Unfortunately, no. I haven't been directly involved with a whole lot of sports medicine stuff. So the way our program is set up is a little bit different. I'm at an outpatient orthopedic clinic, but a lot of that is older individuals that aren't necessarily into sports. But I have had some previous exposure, and we'll kind of get into some of the post-op and avulsion fracture stuff in a little while, but I've got a personal story that I'll share about a freshman outfielder who's a baseball player who had a similar injury like that. These are finicky injuries. After working at the college level and the professional level, it doesn't surprise me how often re-injuries occur, but it does to some degree that they're entered back into return to sport, possibly a little bit earlier than they probably should. But again, there's a lot of factors that go into it, and so we'll kind of get into some of that. But not a whole lot recently, but in the past, I've had a few that I got to work with directly.
Absolutely, man. The athletic training life will definitely open you up some hamstring strains. They definitely come in and out. Yeah, for people out there, those that don't know what your hamstring actually consists of, there's three main muscles. There's your biceps femoris, your semimembranosus, and your semitendinosus. Now, how bad your hamstring strain actually is depends on which muscle is most often injured. So the bicep femoris is actually the most often one that's injured, and it kind of occurs whenever you're in that last phase of high-speed sprinting and you're trying to slow down your leg as it comes in contact with the ground. This usually has a better prognosis just because the muscle itself is usually where the injury is at, or the musculotendinous junction, as opposed to when you enter the semimembranosus, it usually has a tendon tear inside of it. And then, as we know, like tendon doesn't receive a lot of blood flow. So that's going to be the main priority factor when you go forward to your rehab, is trying to understand that that is going to take a lot longer to get back. It should not be pushed as fast as a biceps femoris strain or injury. So yeah, I mean, hamstrings are pretty much graded on a Simbro scale, 1 through 3. Grade 1 being the most mild, which is kind of dependent on like the amount of pain you have, the weakness, the loss of motion. Grade 2 is a little bit worse than that, and obviously like grade 3 is the worst hamstring strain you can have. It either involves a complete tear of the muscle itself or an avulsion fracture, which we're going to get to here in a little bit. Yeah, so some like risk factors we've seen through this. So some non-modifiable risk factors. So these are some things that we can't change. This is the age of the individual, prior history of hamstring strains. You know, hamstring strains are kind of like ankle sprains. If you have one, you're really more likely to get one in the future. Things that you can change, though, is you can understand that hamstring weakness, the ratio from hamstrings to quads, your fatigue, core flexibility, these are all things that can be worked on inside the weight room, out in the field, through different activities and your drills and your given sports. But yeah, I mean, like, obviously want to prehab every injury. What are some exercises that you like to do for hamstring strains to prevent injuries out in the field? Is there anything that you like to target in any of the athletes you worked with in the past, or is there things that you're doing right now that are really beneficial?
I think the biggest thing prehab wise is especially for our high level sprinters, whether that's basketball, track and field, football, even baseball. This is a highly active muscle in the eccentric portion of that knee and hip motion. And so I like to work a lot of eccentric stuff. Something that I think, Jake, you're probably familiar with, is something called the Norton. I don't use it very much, but eccentric exercises like that, using that type of equipment, is something that I like to focus on a lot. One thing that I've done recently, and I might be able to even demo a video for you all at some point, but it's a glute bridge with an eccentric hamstring rollout on a Swiss ball. So you do your typical glute bridge, and then you, on a 3 count, 5 count, 10 count, however long you feel comfortable with, you're rolling your feet out until you get to a point to where you're in kind of a flat bridge where just your shoulder blades are touching the floor, and maybe some arms out to the side for some core stability. But that even could become a core stability exercise if you take away the arm support. That I like to use. I don't see a lot of like reverse hyperextension use. To me, that it's a fair exercise. I just think if you do it well, it can work, but I think it puts a lot of strain on, or can put a lot of strain on people's lumbar spines and hips, and we don't really want to do that if we're just trying to get the few benefits for eccentric hamstring strength, and doing stuff like that. So.
Yeah, that's great. And one of the biggest things that we popped up in our research when it came to prehab and rehab is that lumbopelvic rhythm. So what that means basically for our viewers, as your back works with your pelvis, they kind of move together. So with our hamstrings, they're attaching onto the bottom of our pelvis. So everything is just this one big chain of movement. So we need to understand as professionals, and we want our athletes to understand that lumbopelvic rhythm, as that's moving, that's going to have a big effect on hamstrings. So just because it's on the legs doesn't mean that this whole chain isn't affecting our movements.
Mm-hmm. Yeah,
absolutely. Yeah, and to speak to your Nord board, I love the Nord board. I think it's one of the coolest tools that's come out in the past few years. The design of it's really simple. For those of you out there that don't know what a Nord board is, typically if you imagine like you're on your knees and somebody's holding your ankle and you're trying to decline to the floor as slow as possible, what Nord boards can do is resist your hamstrings and feel that eccentric strain. And a lot of times you can even measure the output that you're having in that muscle, compare it side to side, and be used as a risk factor to prevent injuries. A lot of professional teams are moving towards this to use and monitor for hamstring strains, which is one of the most prevalent injuries out there. But yeah, even the old school way of just holding your ankles down and declining to the floor works just as well. That can be utilized at all levels of sports to try to prevent this injury.
And if you don't mind me interjecting here, Jake, one thing that I think the Nordic hamstring again, and I this one I had a brain fart and I completely forgot this one. That's another fantastic exercise for that eccentric hamstring strength. One thing that I will say is to stabilize the pelvis and the low back, like you were talking about, Jake or JJ, with the lumbo-pelvic rhythm. But an exercise like that is also a really good one to work kind of more from the proximal standpoint, where you're getting the longer lever arm on the moving end, and so you're kind of stretching out the muscle, making it work towards the proximal part of the muscle towards the insertion. One thing I will say for that exercise, if it needs to be like graded forward, progressed, or regressed, one thing that I've done in my own personal training is I've used like a TheraBand or just some type of resistance band wrapped around my chest. So that gives me a way to lower myself down in the eccentric, fight gravity so much coming into the concentric phase back up to the start of the exercise. It's something that I think has been beneficial, especially for people that are just starting to do that exercise. Gives you a feel for what the exercise is supposed to feel like, and then you can grade it down based on the different colors of bands that are out there to get different strength benefits, concentric and.
Absolutely, that's a great idea. And even going off of your bridge with the Swiss ball, what I like to do to grade up is take a resistance band and tie it around people's feet and then pull out so that it's just that little bit of extra oomph that they need to control as they're going back. So definitely something you can work on as you go forward, especially when you're advancing that rehab protocol.
Yeah, definitely. And something that kind of sucks for this is obviously the neuromuscular control aspect of these prehab plans is the most crucial part in this specific injury prevention strategy. But unfortunately, like a lot of times this does occur no matter how much we can try to prevent it. And a lot of times if it is a proximal hamstring avulsion, it does have to have surgery, as all of us are aware of. So typically what the usual guideline is that when you have an avulsion fracture, if the end of that fracture piece is distal from 2 millimeters of where it displaced, that's usually when the surgical consultation has to happen. Otherwise, the two ends can kind of grow back together and you don't have to necessarily worry about having a surgical output. But the issue with this is sometimes a hamstring strain can only take a few weeks to a few months to deal with, but the recovery process from a surgery takes up to 6 to 12 months, which it lingers and lingers and lingers. Guys want to come in. They come in after having too short of a return to play protocol. They go back out, and it's kind of what we talked about earlier. It's one of the most finicky things we have out there, you know? I mean, it's hard to judge how muscles are going to go contract together until you start doing sport-specific activities. But if you're not in a stabilized position to go into that sport, that's where we kind of see more of these re-tears happen all the time, even after surgery. So, Tim, I know you had an avulsion fracture athlete in your past. Do you want to speak a little bit towards that?
Yeah, so I'll give a little background. So this athlete was a baseball player, an outfielder, and so the initial injury, and unfortunately I didn't get to work with him for his entire rehab. I just kind of came in towards the later phase as cycling exercise, walking, running, jogging, and back to baseball specific skills. But from what I had understood after some chart review and speaking with the athletic trainer that had worked with him, he had the initial injury probably the start of summer workouts. This is one of those things where it just it didn't really get better for a couple weeks. You know, saw the overseeing physician, didn't really wasn't diagnosed with anything other than a hamstring strain, just your typical, I think it was a grade 2 hamstring strain. And they just worked on it, wasn't getting any better. So they went back and they did some more testing, still wasn't getting better. So I think after about a month, finally went in and had an MRI done, fracture of his proximal hamstring. I don't remember specifically what muscle it was, but they ended up having to go in and do a surgical repair. So once they did the surgical repair, there was some other outlying issues that unfortunately occurred. And so it took this athlete quite a bit longer than to walking, running, and then baseball specific activities. So this is a situation where sometimes, it's hard to tell what exactly happens when you get that initial injury. And sometimes, you might think it's a traditional hamstring strain and it just doesn't quite get better after a couple weeks. You're not showing, and sometimes edema that's associated with these injuries can occur. And if those things aren't really changing, or I shouldn't say changing, but aren't really getting better with, that kind of into that subacute phase of healing, then I would say that's a cause for concern for any athletic trainer or PT or someone that's monitoring an athlete's performance.
Yeah, definitely. So something with that, like obviously a rule that we're starting to learn as student physical therapists is that if your patient doesn't improve in 2 to 3 weeks after treatment, there's probably an underlying factor that's going on that either needs a second opinion or a surgical consult, something that's not allowing the prehab or rehab to go forward. We actually looked at a study covering hamstring strains specifically, and it's interesting because the clinical output of diagnosing a biceps femoris strain was the same using clinical standards versus MRI diagnosis. But the issue comes in is that's specific for the biceps femoris, but when people injure the semimembranosus or semitendinosus and they have an injury to the tendon, the avulsion fractures are kind of where that the MRI or X-ray or something to look deeper inside the bone is actually indicated. And obviously, like those are tough because, as clinicians, we want to be able to fix everything inside of what we can do and handle with our own hands. But, obviously once you get that avulsion fracture, that pushes everything a lot farther back and makes the rehab take a lot longer than most athletes want to get back out in the field.
Yeah.
But yeah, man, that's really common. Even working in track in college, I remember watching a lot of sprinting events, and whenever we'd have somebody tear their hamstring, like, man, like I just feel like I got shot in the back of the leg, and you can just see the person just go down. Like it is not an easy injury to sustain. It's usually a very loud and audible pop once a hamstring goes, and honestly, like it sucks.
Yeah.
It is not great.
Yeah.
And then the closer that the hamstring tear is up to the ischial tube, the longer the rehab takes too. But some things that we've seen through rehab is that you need to be able to train eccentrically at some point to get back to sport appropriately. But the issue is that you don't want to do it too soon because you might injure the tear that's already happening, and you might facilitate further injury that's going to regress you. You don't want to do it too late either, just because you have to account for that in your return to play protocols as well. So in the acute phase of rehab, we typically know like the Rice method of everything, with dealing with injuries and things like that. What were some of the things that you did early on in your baseball player's rehab protocol, just to kind of like manage where he was at with his pain, with swelling, trying to get range of motion back? Did you guys do any like neuromuscular control type things or anything like that?
So it started off as pretty basic because of the avulsion injury, and per the surgeon's protocol that did this surgery, we were pretty limited as far as even the passive range of motion restrictions that we had. So it started off very basic, and it was, if I remember correctly, they were in a rehab brace that only had a certain range of motion blocked off. A telescopic brace, I guess, is what they typically call it. For some reason, I'm not drawing a blank there, but so we were fairly limited on the range of motion we could do. After that, it started with some assisted active range of motion, strictly concentrically. I think that was the biggest thing that I took away from it was we were moving into shortening the tendon, shortening the muscle belly to stay away from pulling on the screw that was inserted into the ischial tuberosity. So a little bit of that, and then we moved into some active range of motion once the pain from the initial injury and the post-op edema and stuff had kind of settled down a little bit. Then we moved into active range and moved into more of some eccentric work, but very, very slow and graded. Like you said, Jake, is very easy going, especially early on. You want to make sure that avulsion is healed and ready to handle the forces that the muscle is going to subject it to. So that's pretty much what I can offer as far as that rehab goes. I think it was pretty tough for the athlete. They've always been from what I can remember, they were always a high level athlete, didn't really weren't subjected to an injury like this, and so it was tough being away from the game for a while. But I tell you what, when we got him back to where he could swing the bat again and maybe play a little bit of catch, it was quite the good feeling to a bat. And I think quite often athletes who have good health and aren't injured as often take that ability for granted, and it kind of helps athletes that do get injured reframe their mindset on, I really do have it pretty good. I'm back to full health. Let's make the most out of it. So.
Absolutely. And the toughest thing with that acute phase is it's so boring, like for the PT and for the athlete. You want to get them back there. They want to get back out there. They're as competitive as possible. But you just got to make sure you don't push it any further and make it any worse. So let's bridge that into the next subacute phase. So as you were moving him along and you got starting to do a little more movement, what did you bridge into there?
So as we got past kind of the active assisted range of motion is really that part into the subacute phases where we really push to get full range of motion, back into full knee extension, working on hip flexion as well. And so that's kind of where we started. And then once we were up to isometric hamstring contractions, we didn't do anything like serious manual muscle testing or what you would see with a typical manual muscle test, but it was more of like pushing up against the wall hip extensions or quad sets or quad and glute sets, working on trying to just get that knee back into full extension, because for a while a little bit of a flexion to relieve some of the tension on that avulsion repair, but he that's kind of what we worked through in the subacute phase, getting back to full active range of motion. And then I think another thing that we focused on was normalizing just his walking gait. After a fairly brace, it kind of changes up your gait pattern. And so normalizing his gait and getting him back to walking without any issue was one of the things we wanted to do. Because that then goes into our chronic phase, or kind of the end phase of healing before we get into return to sport, where we're working on a really light jog, sport-specific activities, where he needs to run like he did, may not necessarily have the same gait pattern that he did. So that was our goal towards the end, was making sure he could run without any issues, and then getting into change of direction and all that multiplanar movement that you would see in a return to the sport protocol.
Awesome. Yeah, something that's really interesting now, like going back through PT school as opposed to just learning rehab through athletic training. One of the things that like our coursework really hammers down is lumbopelvic control, or neuromuscular control of our lumbopelvic region. And a big criticism that most people have for hamstring rehabs is that they don't utilize this lumbopelvic return technique, and they don't do a lot of this neuromuscular control in addition to hamstring strengthening. In the Journal of Orthopedic Sports Medicine in 2004, they came out with this article, and it basically showed that progressive agility and trunk stabilization, after going through so many weeks of this, the injury reoccurrence for hamstring strains was 0% at 2 weeks and 8% at 1 year, which is incredible. Like, those are great numbers. But then when you compare that to just progressive strengthening and stretching alone, at 2 weeks, it was at 55%, and 1 year is 70% re-injury rate. So, I mean, it's massive, that amount that, you know, we want our rehab to be complete. You know, we don't want to just focus on what's torn. We want to figure out why it was torn. The majority of injuries that happen occur because there's some sort of biomechanical fault. So whether this is baseball, whether this is football, whether this is soccer, you really have to look up the chain. You have to look down the chain. Was there too much deep valgus? Was he planning too much? Was he in an anterior tilt position that put in more prime spot for the hamstring to tear? And, you know, it's kind of wholesome, and it makes me realize, like, going back to school is the right choice, because we can identify these things so much better now that we've had more advanced training. You know, I mean, physical therapists, man, it's amazing what you can look at a person now and see what's going on with their body just by observing how they move every day. You know, I mean, it's one of the reasons why I love this profession. And I mean, it's such a great feeling to be able to be like, I know you had an injury. We can fix that injury, but we're going to fix why that injury happened. You know, we're attacking the root cause of everything and not just like the secondary symptoms. So, yeah, I mean, that's just something that I have a little soapbox on, but I get really excited about.
No, I agree. That is a really cool benefit, and I agree. I'm glad I decided to go to physical therapy grad in athletic training. Not to say that the athletic training profession isn't a fantastic profession. There are people in that field that do things that I could never even dream of doing. I just think physical therapy was the right path for me, and athletic training in undergrads did a fantastic job of setting me up to be a successful physical therapist. There's still things that I draw on from my athletic training background while I'm in PT of mind on, while I'm doing an evaluation on a patient, or coming up with a different therapeutic exercise progression, stuff like that. So that's kind of my soapbox. I won't stay too long. I know we got a couple more things to talk about, but yeah, it's pretty cool that we're doing what we are doing.
Yeah, and
go ahead, you're good.
No. So one of the biggest things that, you know, we're excited about, and that we talk about a lot, and that we actually got to speak to a surgeon about, is just the ability to have an evaluation of a healthy patient, relatively healthy patient that might be at risk for a hamstring injury. And like Jake was saying, that there are these easily identifiable risk factors that we can look for and change prior to that injury. So I think that's something we're really excited about, and we want to push through our PT practice. So I wanted to see, Tim, just like your point of view on that, just that prehab aspect and how you see our role with that.
Well, I really like it. I think that's an interesting question. Fortunately for us in Kansas, we do have direct access. So that's something that I think sports physical therapists and just general outpatient physical therapists find a really strong benefit. We are able to pull patients in off the street, and, like, for instance, myself, I'm actually going through a little bit of a knee injury right now. I could just there's a physical therapist that has come in and gave a couple of guest lectures, got in contact with him and said, "Hey, I'm having some issues. Do you mind if I come in and see you?" He said, "Yep, we'll find a time for you." And I just walked in the clinic. There's no physician referral, no issues with trying to get in on a schedule or seeing a primary care physician first and then heading over to physical therapy. So I really like that. And for our athletes that, you know, coming as a former athlete myself, getting right into a physical therapy clinic after an injury is, I think, a fantastic benefit. Now, I know that's something but I think it's something that we can I guess I'll say we really appreciate to have here in Kansas. As far as where we're going, I think it would be really cool to see physical therapists become almost like a primary care provider for musculoskeletal conditions. That could be a ways down the road before that type of understanding of the strengths of our professions and capabilities of our profession comes into play. But I think patients are starting, especially in Kansas, are starting to recognize that our profession does have the ability to diagnose and rule out comorbidities and factors that may necessitate a referral to a physician. You know, we are a doctorate profession. We are in every state. Not to say that we don't want to make have a good relationship with our orthopedic surgeons, our family physicians, our physiatrists that do a lot of pain management and other things like that. But I think for your primary musculoskeletal, knee pain, hip pain, back pain, shoulder pain, I mean, you can go up and down of different issues that someone might have. I think physical therapy is the way to go, and I think it will become the place to start.
Definitely, man. And one of the cool things, I love following up with you. You're one of my favorite people to look at on social media. But I know recently you just went to a conclave in Washington, D.C. over legislation that's being passed, what we can do as like a student body. Before we close up, do you want to talk about some things that you guys focused on over there, some points of emphasis that were a priority for the student body as well as the main body,
Sure.
anything like that?
Yeah, absolutely. So one of the big things, and I'm sure you're both aware of this, and kind of the entire physical therapy profession is being made aware of, is the opioid issue in the United States. I think today there was actually an indictment of a handful. I don't want to say handful. I don't know whole details, but there was a group of physicians that had just gotten in some type of legal trouble for over prescribing opioid medications somewhere. I think Ohio, Kentucky, West Virginia, somewhere over there. So a big push for us is we are a non-pharmacological option as physical therapists to treat musculoskeletal pain, whereas the model before was prescribed. It's just something to mask what's going on and not necessarily a treatment or correction of a biomechanical issue that's causing the pain. So that was kind of the overarching principle of the forum. Is that's what we're really focusing on. We want to help get patients access to care so that they don't have to necessarily turn to these types of drugs. Need this medication to function. I will say that there are people that just cannot do their daily lives without some type of opioid to help them because they are in so much pain. That being said, they are the ones that have used physical therapy. They've gone to ulterior methods to treat their pain, and just the opioids work for them. But I think that physical therapy can work for a lot of people. The opioid epidemic was one. The second one, from a student perspective, and this one might be pretty cool for both of you, is the National Health Service Corps. So what that is it's a program where medical students, and I think medical professionals, medicine, nurse practitioners, physician's assistants, behavioral health, and a few other health professions can apply to federal assistance and student loan reimbursement for a commitment to serve in an underserved or rural population. So for me in Kansas, that is half of our state. If you look at the western half of Kansas, it's an underserved population. I have some family friends that are farmers in western Kansas, and they have to drive 45 minutes to see pretty much any type of specialty physician. I mean, anything, ear, nose, and throat. I mean, any specialization, they have to drive close to 45 minutes to get access to that. And so adding physical therapists to that program is something where we can help get patients access to care so that they don't necessarily have to turn to opioids to manage their pain. You know, a lot of farming is a really tough, farmers are really, really tough, gritty people. And so sometimes they just swallow they just don't worry about it. They're like, my shoulder hurts, get up and go. You know, we have work to do. So if we can get them some care, we can get a physical therapy profession or occupational therapy profession out to deliver them care. It may be beneficial to them so they don't have to turn to opioids, and they can continue doing their job. They can continue to provide for their families and provide for the world. And so that was the biggest push for us as students. And then the other thing that they talked about was getting physical therapies placed on the community healthcare centers approval list. So right now, I think medicine and a couple other non-insured patients at a community health center basis. And so putting PTs in that space as kind of like a primary musculoskeletal treatment profession in that center, that type setting of care would be another way that we could help mitigate some of this opioid crisis. So overall, it was to kind of help help fight the opioid crisis and how we can address those issues through different avenues.
That's awesome, man. That's great work. I love hearing about it. You know, it's really inspiring coming from people that aren't quite certified yet. You know, to start this push early, because it's something that we're going to find in the long term through our entire career. It's not one of the reasons, honestly, why we started this entire company. It's why we do things like this. You know, health literacy is so poor as well. Is that, you know, people might get prescribed something, they might have a diagnosis, they might hear that there's something wrong with them that they don't know what it means. And, you know, just to take the time to let them know, here's what these medical terms mean. Here's what your diagnosis means for you. Here's how we fix that diagnosis. And here's how, you know, this telehealth movement that we're trying to jump on the front end of, you know, it's for that person in rural Kansas. It's for that person in rural Pennsylvania.
Mm-hmm.
The people that aren't going to be able to see anybody because they are in the middle of nowhere. Just for them to have an outlet, to understand that, hey, you know what? You guys are talking about a pain in the back of my leg. I was on the farm yesterday. I was lifting the hay bale and I felt like I got shot in the leg. So maybe this is something that I can deal with, you know?
Yeah.
And it's just, it's for the everyday person to understand that healthcare shouldn't be something to shy away from. It's okay to reach out and get help. It's okay to tell somebody that you don't understand what's going on with you. It's our job to tell you what's happening, to walk you through that with you, and to be able to make goals based off of what you want to get back to and how you want to do it. So yeah, I mean, like the whole opioid thing ties into all of that. You know, those are huge issues in the PT world. It's huge issues in the world. But yeah, man, I really appreciate you coming with us today. It's been awesome talking to you. It's something that we should do again in the future because I love you, man.
Yeah, that's cool. So if you don't mind, Jake, one thing I will say is this is just a disclaimer there. Everything I've shared today is from my own personal experience. Doesn't have any affiliations with KU Medical Center or Kansas State University or the sports medicine. These are my thoughts and my opinions on how I think hamstring injuries should be treated, and what I've seen that has worked and what I've seen that can be improved, and then kind of my thoughts from the Federal Advocacy Forum. Just wanted to make sure I was on record mentioning that in case I don't anticipate any naysayers, but just in case someone says, hey, well, are these somewhere else? I'm like, well, we have our resources cited, but this is what I formed. I can think my own thoughts. So
we have it on the official record.
We appreciate that, brother.
Sure thing. Well, again, thank you both so much for having me. I think you guys are doing some awesome stuff. I try to like and retweet and give your content the love that it deserves, because I mean, this is really cool stuff, and you're giving information to people that may not otherwise have access to it, to be healthier people, to be better athletes, to build better athletes, to give them the tools to take care of themselves. So I also will say I appreciate the golf series. I've had a couple of those exercises put in the back of so I don't hurt myself while I'm out on the course. So thank you for that.
We really appreciate it. We appreciate your time. We know your time is valuable. So like Jake said, you know, we're going to do this again, and I hope it benefits a lot of people. So, you know, thank you, and, you know, have a good one.
Absolutely. Thanks, guys.